had a really good discussion about looking at the patient as a whole, and how does the real world data affect your practice? You know, there's all these things you see in the real world, okay, age above this, or maybe this is not good, or like you were mentioning, like, do you use it as a tool to complement the clinical trials, or do you just go by the patient and your experience with a particular?
So a few points. I think there's not all real world data are created equal. So there's real world data that we all generated when we were in our training, right, going through retrospective patient charts. But now there's real world data where they have very specific guidance, even from the FDA, about how to do it appropriately. And they've managed actually to get some real world data into approved packets for patients based on the methods they use to obtain those data. The problem is I recently saw a presentation with real world data, and I could pluck out an argument for any agent based on whichever slide I chose. Right? There was an argument for apalutamide, there was an argument for Zytiga, there was an argument for darolutamide. There's arguments across the board depending on which data set you're using and what your question is. So I think it's helpful in terms of, I would call it practice confirming. Sort of helps you say, yeah, it's kind of what I'm seeing in practice, but very rarely, if ever, is it practice changing.
Yeah, just informing.
Yeah, I think it's the person sitting in front of you, who are they, how old are they, what are their expectations, what are their comorbidities, what side effects are they willing to accept. I think that's really how I make my decision.
Yeah. So, I mean, we all are using a lot of lutetium in our practice. We also have clinical trials, and looks like we're also using radium-223. So,
yes.
This recent trial that came out, the COMRADE trial, which was combination of radium-223 with olaparib in metastatic CRPC patients with bone mets. It showed a PFS improvement of 4 months, regardless of the mutational status. Now, what are your thoughts on it just from a high-level view? Like, to me, it's a little scary combination, for that 4 month, regardless of HRR. But I would love to hear what, because we can see some really bad toxicities with PARP inhibitors and also from radium. So are you impressed with the fact that unselected patient population, 4 month PFS improvement if you add a PARP to radium?
I probably wouldn't do that if I had that available. I mean, we saw with Talaprod too, with the Enza and Talazoparib, they showed, benefit in an unselected population, but, obviously that has not come to fruition into practice, and so I probably would not be routinely doing that.
One of the things that I might, if I have a very motivated young patient that wants to do everything under the sun, or there is a date that they want to accomplish, like a wedding, a birthday, so it will be an exceptional situation. It's nice to have that option, understanding the potential side effects, so that's one of the things that sometimes we do as an oncologist, but it will be a very selected situation.
Just like, to your point about the Talapro, and that's the reason the FDA gave that to benefit one person, how much toxicity you're causing in, a whole lot of people. So I think that's very reasonable.
I think in the treatment refractory, incurable setting, you need to see an OS for something to be considered a standard of care. If it's just a PFS benefit, especially when you consider giving a PARP inhibitor with radium, and you start to think about what the hemoglobin's going to look like.
Yeah, the cytopenia.
Yeah.
It's worrisome.
So let's say, if in your practice you had access to radium, looks like you had, and now for whatever reason you don't, but you don't have lutetium, and sending to the main campus would take another few weeks. Would you go ahead and start radium in the eligible patients, or would you wait for lutetium?
Yeah, if they are eligible, I would.
Mm-hmm. Yeah, I have no issue doing it. I think there's a benefit in the right patients.
Yep.
And it's pretty well tolerated.
Yeah, it is.
Yeah,
and it causes all those benefits, right? There was a survival benefit, there's a quality of life, reduced fracture risk.
I know sometimes when we look at the label or at the, up to date, it says it's to be used in patients who have symptomatic disease, but I've never had an issue getting it approved for patients who have bone-only disease with no symptoms. I would say because there's an OS benefit, it's appropriate there also.
Yeah.
There's a role for all these buckets and for all the drugs in the buckets. By the way, there is actually data that was presented, I don't remember if it was at ASCO or GU ASCO, about patients' access to lutetium. Because it's a real thing. I mean, we talk about, many of your patients are probably, some of them might only be 1 to 2 hours away, but there are patients in other regions in the country that it's a flight to get lutetium.
Yeah.
So whether it's because of access to have radium as an option, or it's because of, at the end of the day, there was an OS benefit
Yeah.
in the trial, there's still a role to use it.
And it's well tolerated. So I actually still use it quite a bit, and it's very well tolerated.
And interestingly, with lutetium, I know it's a great tool, very effective, and especially in heavily pretreated. In Vision, the control arm was not that. It was, I think it's like another ARSI basically. You couldn't give chemo, and so all the trials where they did therapy, it didn't beat cabazitaxel in terms of efficacy. It's better tolerated. PSMA4, it was against the second ARSI. So I don't think we have other things. If a patient can't get lutetium, we have other things that are not necessarily compromise an efficacy outcome.
Yeah. I mean, I know there's always the, craze about the latest
Yeah.
toy out there, but it's not always the case.